Bismillahirrahmanirrahim. I am Dr. Hasib Ilahi, Assistant Professor Orthopedics and Spine Surgery at Shalamar Medical and Dental College. Today we will be discussing about emergency triage assessment and treatment. Emergency triage assessment and treatment is very important part of our clinical skills, mostly used in emergency situation in the hospital or outside hospital. So the format of the course will be introduction, participant instructors. There will be pre-test, post-test, and those who could not get through will retake the test, and then we will have and then group photo. Course outcomes. Our objectives are the definition of the emergency triage, understand the principles and importance of the triage in emergency, recognize emergency and priority signs using a systematic approach, categorize patients as emergency, priority or non-urgent. Critical review, first look or rapid assessment, learn triage documentation and infection control, initiate basic life-saving treatments including airway management, oxygen fluids and glucose. Communicate effectively during the triage and refer patients accordingly. We will have the 6 modules. Introduction to the triage and emergency triage ETAT. Learning objectives. Define emergency triage and its purpose in emergency care. Explain ethics, safety, doing the greatest good, protect the providers and the patients. Describe ETAT categories: emergency, red, priority, yellow, non-urgent, green. Recognize triage as a team process, nursing, medical, allied roles. What is triage? According to the National Emergency Nurses Affiliation 2002 definition of the triage is a sorting process utilizing the critical thinking and standardized set of guidelines in which the experienced registered nurses assess patients quickly upon their arrival in the emergency department to assess, determine the severity of the presenting complaints, process patient into triage category and streaming to an appropriate location, determine access to appropriate treatment effectively and efficiently, assign appropriate human health and resources. Evolution of triage. Military routes. Introduction to the hospitals in early 1960s. Number of the cases increasing in the hospital. People with the non-urgent conditions come to emergency department for their treatment. That was the major reason that led to the evaluation of patients and evolving of this triage system. Initially 3 triage, emergent, non-urgent and non-urgent was used in 1999 Canadian triage and scale. CTAS 5-level triage implementation guideline published as recommended national guidelines. Benefits of triage: improve patient care, ensure critically ill or injured receive priority attention, establish the severity and anticipates the resources needed, predicts how long the patient can safely wait, support an effective utilization of spaces and resources, improves the communication and public relations. Emergency patients are unique because they are unscheduled, anxious, distressed. Patient and care providers are the strangers. Patient experience symptoms, not a diagnosis, span all ages and types of emergency. Not all patients are as well as they appear, and not all patients are as sick as they think. Role of the triage nurse: assessing the patient and determining their severity. Communication with the health professional determines the treatment location, initiating the treatment protocols, first aid measures, and monitoring and reassessing. Participating in patient flow documentation. Triage nurse. What makes a good triage nurse? Personal traits, cognitive characteristics, behavioral characteristics. Personal traits. A patient, an emergency nurse should be flexible in his character, autonomous in his decisions, effective communication skills, and must be patient, should be assertive and compassionate with the patient, willingness to listen and learn. Cognitive characteristics: Diverse, knowledge base, knows when to act, use critical thinking, able to make decisions quickly, able to prioritize. Behavioral characteristic: a patient advocates, work well under pressure, organized, able to improvise, applies intuition, confidence in judgment. Triage nursing skills: public relation, interviewing, critical thinking, communication. Patient arrival: a variable percentage of the patient arrive by ambulance. The severity ranges across all triage levels. More patients arrive by the other means of the transport known as walk-ins. Their severity includes all levels. Patient increasing in hospital. What are the reasons? Public awareness is the main reason. Referral system from the primary and secondary healthcare levels. Ambulance services developments that led also to the increased number of the patients in the hospital. Technology and telemedicine. Crowd control in our Pakistan, Urdu is the national language. So in every emergency there should be a board जिसमें लिखा होना चाहिए कि इमरजेंसी डिपार्टमेंट में मरीज़ों का इलाज उनकी मरीज़ की मर्ज़ के नौयत के मुताबिक किया जाता है. इमरजेंसी डिपार्टमेंट नियरेस्ट टू द हॉस्पिटल मेन एंट्रेंस, यानी ये कहाँ पे इमरजेंसी डिपार्टमेंट होना चाहिए कि जैसे ही मरीज़ का जो मेन दरवाज़ा अस्पताल का उसके साथ हो, ग्राउंड फ्लोर पे होना चाहिए क्योंकि हर तरह के मरीज़ आते हैं उसमें. उसके साथ रैंप की अवेलेबिलिटी हो ताकि अगर मरीज़ स्ट्रेचर पे है तो भी वो पहुंच सके, और स्टाफ और ट्रांसपोर्टेशन वहाँ पे एडिक्वेट होनी चाहिए. ट्राइएज रूम एंड एरिया नियरेस्ट टू द emergency department main entrance, adequate space, ventilated, heating, cooling equipment availability, infection control equipment. Resuscitation room training, non-metal beds, CPR boards, BVMs of two sizes, defibrillators, separate walls or partitions. Now we move on to the module 2, emergency priority signs. ABCD: airway obstruction, stridor, choking, immediate action. Severe breathing difficulty, cyanosis, very labor. Signs of shock: cold extremities, weak rapid pulses, CRTs. The altered consciousness, convulsions, exposure. Critical look. Critical first look across the room begins as soon as the patient arrives in the ED. Perform a quick check of airway, breathing, circulation, disability. Should take 3 to 5 seconds. Take actions as indicated. Critical look. Infection control. Begins by the patient history. Use latest information available by the department. Provide masks. Presenting complaint. First order modifiers. In presenting complaint, patient-driven complaints. What are concerns brought you to the emergency department today? Headache, cough, which of the complaints bother you most? My fevers and the shaking skills. Triage decisions based on the critical look, chief complaint, subjective and objective assessment, application and modifiers as required, then decide. What is the patient's priority? Categorization. Immediate is one that must be labeled red, urgent is yellow, delayed is green, and dead is black. Key concepts. Triage, rapid sorting at arrival, right patient, resource and right time, identify life threats within minutes, scope, recognize and first line treatments, safety and infection control, standardized process, improves outcome, dynamic reassessment, condition change, use simple language with patient and family. Red is the immediate, yellow is the urgent, green is the non-urgent, and black is the diseased. Priority signs: 3 T's. Tiny infant less than 2 months, temperature abnormal, trauma, pallor, poisoning, pain, severe. Respiratory distress without failure, malnutrition, edema, both feet burns. Documentation is very important. Patient name, age, date, time, presenting complaint, subjective assessment, objective assessment, triage level, nurse ID, allergies, medication, immunization, past history, interventions, triage disposition, reassessment. In Module 3, triage flow and classification. When lineups form, scan for the critically ill patients and move them to the front of the line. Anticipate reprioritization, know the status of the available treatment areas, stay calm, request help when required. The goal is to triage the patients within 10 to 15 minutes of the arrival. Patients in the waiting room, the number of the patient waiting and their wait times have been increased. Advise patient to return to triage desk if condition changes. Depending on the hospital site policies and medical directives, triage nurse may need to initiate diagnostics, provide symptoms relief, dispense analgesic. If numbers are overwhelming, call for assistance. Vital checks. ECG in 10 minutes of MI suspect should be done in emergency department. Level 1 and level 2 vitals should be checked by the triage nurse as per vital checks. Doctor led triage at rapid assessment treatment. The doctor sit with the triage nurse and check the patient quick medication and asking for the next day OPD. This is the adult triage sieve. You can see if the patient is walking, yes or no. If the patient is breathing, yes or no. Then these are the next steps. If the patient is walking, if his patient is walking, yes. Is patient injured, yes or no. Then if the patient is not injured, then delayed priority. Then we will check the patient breathing. Is the patient breathing? No. Airway maneuver, breathing is secured. If yes, immediate. If no, then dead. If patient is breathing, and we will count his breathing rate. If 10 to 29 beats per minute, what is his pulse rate? If pulse rate is less than 120, then urgent priority. If greater than 120, immediate priority because of the tachycardia. Adult triage sieve. According to the adult triage sieve, delayed P3. Is the patient walking? Yes. Is the patient injured? If yes, delayed priority. If no, survivor reception center. Urgent. If the patient is breathing, yes. What is breathing rate? 10. If it is in 20 to 29 beats per minute, yes. What is the pulse rate? Less than 120, urgent priority. Immediate P1 is the patient breathing? Yes. What is the rate? If less than 9 or greater than 30, no. Then we will count the pulse rate. If pulse is greater than 120, then immediate priority must be given. If the patient is not breathing, we will secure his airway, and if patient started breathing, we will give him immediate priority. If patient arrives with no breathing, airway maneuver doesn't result in breathing improvement, then patient should be declared dead. So this is the summary which we already described. These are some skills we need to learn: airway and breathing, positioning of the head, tilt, chin lift, jaw thrust, if trauma suspected, suction, secretion, vomiting, considered oral airway, high flow oxygen for the distress, BVM ventilation if inadequate breathing, circulation and glucose IV access rapidly, IO if IV difficult, fluid bolus for shock, caution with severe malnutrition, PSSS frequently. Always check glucose in altered consciousness, treat hypoglycemia promptly. Skill stations. These are the 4 skill stations. We need to assess the airway, secure IV, seizure control, hypoglycemia management, hemorrhage control and immobilization. And fifth module is the communication, handover and documentation. SBAR protocol for handover essential situation: who, what is the immediate issue, background, brief relevant history, assessment, key findings and actions done, recommendation, what is the next needed. Stimulation and assessment. Casualty: a 56-year-old male patient, rear seat passenger of the bus, walking, right hand fracture to his right arm, respiratory rate for 24, pulse rate 100. What is the triage category? This is the second scenario in which pulse rate is 34, pulse rate is 100, and abdominal wound. What is his triage category? Treat first, what kills first? Recognize ABCD emergency signs, ABCD primary survey on the every arrival. Act as you assess, use the flow or color tags consistently, triage dynamically, start immediately, life-saving treatment, communicate via SBAR. Teamwork, clarity, documentation, save lives. Thank you.